Well, thank you all for coming. We really appreciate you coming out to the event and wanting to learn more about epilepsy surgery. It's something that has been a part of treating patients with epilepsy for many, many years, but really over the last 5 years there have been significant advances in the treatment of patients with epilepsy. And so we thought it would be really helpful to go through each of the different devices that are made, talk a little bit about what's involved in those devices, let you actually feel the devices, and explain what the surgery involves, and kind of demystify the whole concept of epilepsy surgery. So I'm Vivek Mehta. I'm one of the neurosurgeons at HOAG down in Newport Beach, and we have a comprehensive epilepsy center there, treating adults and children up to age 17 and above with epilepsy. This is Dr. Duma. He's also a neurosurgeon. He's been placing deep brain stimulators for Parkinson's and movement disorders for many years. Probably done more DBS surgery than anyone in the western part of the United States. So together we treat patients with epilepsy. So just to give you some background, we first started doing surgery for epilepsy about 40 years ago. And what people were doing was not really knowing what was the cause of the seizures, going in there and cutting out different parts of the brain to see if that would cure their seizures. Really arcane sort of approach. It actually worked in some patients because, believe it or not, without any information, they were able to find where the seizures are coming from. The next sort of big invention was putting grids on the surface of the brain and recording electrical activity. And then you could find out, well, the seizures are coming from here and here. And then you kind of have a better idea and cut out some of the brain. And really it stayed that way for the next 35 years. Then this device called a vagal nerve stimulator came out. And I'll pass out a number of these if you want to just grab one. These are for people to keep, and the VNS booth is out there. You feel free to go and visit with them, and they'll hand you some more literature and some more of these devices. But yeah, just you can take one and pass it down. And so this is a vagal nerve stimulator.
Those don't work, so don't try them.
So this is a vagal nerve stimulator, and what this device does is we put this in the chest pocket here, and these leads connect to the vagus nerve in the neck. So we make an incision about 1.5 centimeters or 2 centimeters, less than an inch basically. Make a little incision right in the neck, put these little coils, and I'll pass this around, hook these coils onto the vagus nerve, and then tunnel this wire. Everything lives under the skin into a pocket right above the muscle in the chest here. This surgery takes about 45 minutes to do, and patients go home the same day after this procedure. And it reduces seizure frequency and severity at about 60% of the time. So it's not thought of as a curative device, but it's thought of something that can really reduce how often patients get seizures. This is the newest model, the Model 1000, and it's got some really cool features to it. One of the things it can do is detect your heart rate. If your seizures happen to go, your heart rate happens to go up when you're having a seizure, this device will actually go off and try to stop the seizure. And the way this works is the nerve, the vagus nerve, supplies a lot of electrical information to the brain. And by stimulating the nerve, it resets the electrical activity of the brain. So if the electrical activity in your brain is starting to run haywire and you're about to have a seizure, yeah, you can bring that up. This device will reset the electrical activity of the brain. Thank you very much. Getting more models coming in. Good. So this resets electrical activity in the brain. This is not put into the brain. This is just put into the neck. A very easy surgery, fast recovery, a great option for people who don't want any type of cranial surgery, or if the seizures are coming from multiple different parts of their brain and cutting out a bad piece of brain that's causing the seizures, or putting in an implant into the brain is not an option. This is a really, really powerful technique. Some cool things about this new device, the heart rate detection I mentioned. There's also a wand that you can wear, like a bracelet, and it has a little magnet on it. And if you have auras or a sense that you're about to have a seizure, you can hold your bracelet up to the device and it'll trigger a stimulation. And in some cases can stop the seizure or make it less severe or make it less prolonged. There's also new programming parameters with this device. So if you happen to have seizures more at night or more in the morning, they can program the device so there's more stimulation happening in the afternoon or in the evening or when you wake up. So very, very getting much, much smarter. The device itself needs to be changed about once every 5 years. So it does require another surgery. That surgery takes about 15 minutes. Just open up the chest incision. We don't have to go back into the neck. Change out the device, put in the new device, close everything up. Pain-wise, most patients go home just on Tylenol. I don't need to give anything stronger than that. Overall, people do really, really well with this device. I think it's highly underutilized. So if you have seizures, you're not a candidate for any type of cranial surgery, then ask about this device. And the VNS booth is right outside. So, any questions about vagal nerve stimulation, how it works, what the options are, who would be a good candidate for this device? No questions? Yes?
So if you have seizures that they don't know where they're coming from, just generalized, they don't have benefit of auras or whatever, it just happens. Could this be something that could be used to stave off or just, that's what we use?
Absolutely, yeah. Don't know, many different parts of the brain are involved. The imaging doesn't really pinpoint an area. There's, advanced scans like MEG studies or PET scans, or you've had scalp EEG and they just don't know where seizures are really coming from, and you're on high doses of medication, or if you're having a lot of side effects from the medications, definitely ask about, vagal nerve stimulation. The other cool part about VNS is it's been FDA approved for depression. So along with treating your epilepsy, if you have mood symptoms or just difficulty with energy and you're down about your seizures, there's some significant benefits in treating the depression component of the epilepsy. So that's something also to think about. Yeah, please.
But could it be used as a first step before all of that imaging, or do you need to do all of that imaging first? Because we've only done the ambulatory EEGs. They haven't ordered any MRIs or anything else because they believe it is the just generalized and possibly the genetic. So we haven't had any of that imaging with it, but have had a lot of tried a lot of different medications and not controllable things.
Yeah, it's a really good question, is how far do you need to go before you go to this device? You can get an MRI with this device, you can get other advanced imaging with this device, you can have surgery with this device, further surgery in the future. It really is a discussion you can have with the neurologist, and you can say, well, I know I don't want any type of cranial surgery in the future. Some people just say, I don't want you to touch my head. If that's the case, then you can go ahead and go for this device. A lot of times, if we find the focus where the seizures are coming from, we can either do an ablation with the laser, which I'll talk about. We can do responsive neurostimulation, which is a pacemaker for the brain, or we can do surgery and take out that small piece. And there's a chance that if the seizures are focal, they're coming from one area, if we can take that bad part of the brain out, the seizures may go away. So you have to sort of weigh the risk. Well, if I just get this device and I don't do the other imaging, could there possibly be a cure for me that I'm missing? So, but you can talk to your epileptologist and see what they have to say.
You can get the device and it's working or it stops working at the same efficacy it was initially.
Yeah.
Could you still go to the next step?
Yes.
So it's not like you get this, that's it?
No, not at all. Yeah, well, in fact, a lot of patients, they initially have vagal nerve stimulators implanted and they do well. But as we see with seizures, things get worse over time. So you're still a candidate for other surgeries in the future. And you can get MRIs with it. So.
If you have a shunt in for hydrocephalus, would that impact it at all?
No.
Okay.
No.
And
Yeah.
what side effects are there?
Excellent question. So what I tell all my patients, the most important thing to watch for in the first couple weeks is keeping the wound nice and clean and preventing infections. The incisions are so small, the infection rates are pretty low. I've never had an infection with this device, but it's about a 2% infection rate. Other thing people notice is some hoarseness initially when the device is placed. That's because the nerve that we put the lead on does control some of the functioning of the vocal cords. So people get a little hoarse when they first have it, and that usually goes away in a couple of weeks. People also initially report a little bit of a cough when the device is triggered. You don't feel the stimulation, it's not like an electric shock, but when the device goes off, they notice a little bit of cough, and that drops off in a few months. The device does require battery changes, so it is a surgery once every 5 years, but it's a really quick, we don't even put patients to sleep for the battery change a lot of times. It's just a little local pain medication, take the old battery out, put the new battery in, and you're home.
You see the size of the battery?
Yeah, it's tiny. It's really small. So great option to consider. I think this is a really powerful device. Even if your seizures are well controlled on medications, if you're having a lot of side effects from your medication, and with this device, if we can maybe go down on a dose of medication or get rid of one medication altogether, I would consider this device.
Can you go over the ideal candidate?
Yeah, so the ideal candidate for this device is someone who's got seizures that are either poorly controlled or poorly controlled on medications, or controlled on medications with a lot of side effects, like all the other medications that we see with epilepsy, fatigue or lethargy or brain fog or mood changes. So if you're having a lot of side effects, you can ask about this device. The ideal candidate for this device is someone who we don't know where the seizures are coming from, or they're coming from both right and left sides of the brain, and we don't have a way to pinpoint an area to treat it. So this works on the whole brain.
Is there an impact on physical exercise rate when
No, it sits, like I said, it sits right here above the pectoralis muscle in the chest. The first few weeks after surgery, what I tell my patients is don't do any heavy lifting with your arms. Once that device sort of matures in the pocket, there's no restrictions on activity, whatever you want to do. Other questions? Yeah, let's keep going. So let's talk about, since we're sort of in the realm of modulation and devices, let's talk about responsive neurostimulation. So has anyone heard about this device called RNS, or the pacemaker for the brain? And we have someone who has an RNS, I believe, right? We have a couple of people who have RNS. So this is a really cool device. And I wish I had more models of this, but what this device is just like a pacemaker for the heart, where we put leads in the heart that detects abnormal electrical activity and delivers stimulation to break that activity. This is exactly the same concept, but this is way smarter than a pacemaker for the heart. This is a very, very well-designed device that not only understands the electrical activity of the brain, it can treat abnormal electrical activity, and it stores that data, which is then uploaded to a Bluetooth-linked laptop that you get and sent to the cloud, where your neurologist or epileptologist can download that data and see how you're doing in real time. So when you're at home, you're on vacation, you're sleeping, your neurologist can be looking at your EEG at all times. So before we get into a lot of the details, let's just talk about how is this device involved. So this does involve a surgery to the brain. There are two ways of implanting the leads. There are both surface electrodes that we put directly on top of the brain, and then there are electrodes we put inside of the brain, depending on where your seizures are coming from. If they're coming from deep structures of the brain, we put the device into the brain. If they're coming from the surface, we put it on the surface. We connect those electrodes, which are these little tails here, to this little device here, which is the computer. And that lives, I don't know if we can take this out. I think it's locked in this model. But this lives inside of your skull. And the way we get it to sit there is we remove a piece of bone about the size of the device and install a little tray. And the tray holds the battery or the computer. And it's through a Bluetooth connection, it can send data to a computer about the electrical activity. This device is extremely powerful at controlling seizures that are in areas of the brain where we can't laser out or we can't cut out. like speech areas, motor areas, areas involved with sensation or vision, or areas that are involved with memory. So in those what we call eloquent areas of the brain, this is a really good device. This device doesn't often cure seizures. It only cures seizures in about 2% of patients, but it's really, really good at stopping the severity of reducing the severity of the seizures, or reducing the frequency. The best data we have is about 60%. So if you've tried multiple medications, you're still having disabling seizures, and your epileptologist tells you, well, your seizures are coming, you're right-handed, and they're coming from the speech areas. They're coming from the parts of the brain that control your functioning of your hand or your leg, then this would be a good device for you. The cool thing about this device is not only does it stop seizures, it gives your epileptologist information about your seizure activity over a long period of time. So for example, with this device if they add a medication, or they add a dose of medication, and he sees no improvement in the electrical activity of the brain, then we understand that the extra side effects are not worth the medication. Or he may see that, well, you're not feeling any better, your seizures aren't reducing, but the electrical activity is quieting down, maybe we stay on that dose, or maybe we go up on that dose. The other cool thing with this device is how complex the programming is. So there's a couple of different parameters: how much stimulation, how often, how fast. So these parameters can be changed and tailored, and the data that's collected is pooled with hundreds of other patients, or even thousands of other patients. And when we learn that maybe some patient in New York or Massachusetts with the same type of seizures as yours got better with a particular type of programming, we can take that program and apply it to your device and see if that would benefit you. Let me stop there. Any questions about what I've talked about so far with the RNS? Yeah.
To change the programs around, is that done through Bluetooth, or do you have to move the device?
All done through Bluetooth. A little wand, you just come into the office, they put a little wand right on your skin, there's no pain, they download the data, change the settings, and you're done. You're on your way. Yeah.
Are the surface electrodes, are they subdural?
Are they subdural? They're subdural.
Just craniotomy, or is it also opening the dura?
Also opening the dura. They sit right on the surface of the brain. We target it right on the areas where the seizures are coming from.
And how long is the surgery?
So surgery for this takes between, if we're doing a very simple sort of RNS placement, we're talking about maybe 2 hours. If it's a little bit more complex, maybe 3.5 or 4 hours. And this usually requires 1 or maybe 2 nights stay in the hospital. Other questions about RNS? Yeah.
Well, this is kind of VNS RNS. If you have a VNS and you get an RNS, will that improve your chances of more seizure control?
Yeah, they work together. If you have a VNS, it doesn't mean you can't get an RNS, and vice versa. They work differently. The RNS works directly on the areas that are causing the seizures. The VNS works throughout the whole brain to normalize the EEG activity. There haven't been any large studies to look at the combined effects, so we don't know a whole lot about it. But these devices, VNS has been around for maybe 20, 25 years. RNS has been around for about 5 years. So as we have more data, we'll be able to say, yes, that we can understand more how these work together.
She has a VNS already, and she put the RNS in. VNS will be turned on?
No, it's up to the epileptologist, but we can run both together. If we see a benefit, yes. Yeah. Was there a question back there?
My daughter has a RNS device, but can you explain how you work with the Neurosciences company? Because they always come in and they talk, but I don't fully understand how much input they give you and how you use that input, because they have access to this, like they all of you.
Yeah.
How do you?
So they're at most level 4 epilepsy centers where these are placed, there's a special conference for patients with RNS. So we review the data of our patients with RNS and compare it to all the patients out there who have RNS. And the consultants from the company give us feedback. Well, this patient is very similar to this patient here. We tried these programming parameters. Consider trying it on your patient. It's very technical, and I think your epileptologist's job is to interpret and translate the results of that conference and tell you what they think we should do as far as programming. And really, once the device is in, the epileptologist takes over all the programming. Other questions about?
There's so much data and information.
Yeah.
When you say, you look at it and say that there's a reduction in seizure, how do you know that there's a reduction? Is it quantitative, or is it just you looking at it and everything you have done? Because there's so much information. How does the doctor interpret all that data?
Yeah, great.
How can you look at the data?
Yeah, great question. Well, the epileptologists are looking at that data, continuously. There's particular patterns of the EEG that we recognize by looking at, decades of EEGs in patients with seizures, and we know that this is a seizure. This is definitely abnormal electrical activity. So that's how the EEG is interpreted. And we match that up with other things, like a patient log of their seizures. So patients may say, well, Tuesday at noon I had a seizure. We can pull the data from the RNS at noon and see what was going on at that time. Other questions? Yes?
So the metal in it is non-magnetic, correct?
Correct, yeah. This is.
What's limiting right now then from allowing those MRI?
So they've filed for conditional approval for MRI compatibility. I'm being told it's going to be FDA approved shortly. They just needed to show the safety of it. It's usually done in a 1.5 Tesla MRI. There's a special coil, and there's special, when they set the MRI machine, it needs to be done in a particular way. But I suspect by next year, any patient with a RNS will be able to have an MRI. Yeah. Other questions? Yes? Yeah. Yes. Absolutely.
So for repeat EEGs, we put like 28 cortical electrodes. For the RNS, how many equivalent to?
Yeah, great question. So you can have up to 4 electrodes with the RNS. Of those 4 electrodes, 2 can be connected to the device. So the reason for that is this is the first sort of generation of this device. I suspect in the future there'll be more contacts that can be connected. 4 contacts, yeah, but each of those contacts may have 4 to 6, each lead may have 4 to 6 contacts in that. So up to 8 contacts connected.
2 leads, right?
2 leads are connected to the device. Yeah, 4 contacts are, you can implant 4 contacts. Now let's say you have a suspicion about seizures coming from 3 different areas. Well, you'll connect the 2 most highly suspected areas, and let's say you get a partial response or you don't get much of a response. You just make a little incision in the scalp, plug in the lead that has not been connected, and see what you get.
So what's the difference between RNS and the like depth electrodes or those grip and strips?
Yeah, so depth electrodes and strips and grids are usually temporary. They're just done for about a week or 2 while you're in the hospital to understand where the seizures are coming from. This device is like depth electrodes and strips and grids, but it lives in your brain forever. Forever.
And you have to have those tests before that.
Yes, usually you have to have those tests. Yeah. Yeah. Battery for this, usually about every 4 or 5 years. And it's an outpatient surgery. We don't go into the brain. This lives just in the skull, underneath the skin. So we open a little corner, take out the battery, put in a new battery, and you're home the same day. So battery changes with this are not difficult. Other questions about RNS? Do you want to talk about DBS before we do laser ablation, since we're sort of talking about?
Sure.
Okay.
Sure. So your question about deep brain stimulators is interesting because, as Dr. Mehta mentioned, they're usually used pre-operative, like during the phase of figuring things out. So they'll put temporary electrodes in, or they'll slide a temporary electrode down into the hippocampus or the campal area of the temporal lobe. But now there is a new FDA-approved deep brain stimulation technique that just literally was approved within the last year. And it's called the anterior nucleus stimulation. And we use a technology called deep brain stimulation to do that. Anybody in this room here know of anybody who has Parkinson's disease or essential tremor that's had a stimulator placed? Stimulator placed? Well, we've been putting these in for 22 years. Medtronic is the company, and this is the stimulator right here. And the wire it's another one of those under the collarbone, above your pectoralis muscle. The wire goes into the brain to a certain area, and it can stop a tremor, for example. Okay? We've been doing it for 22 years, and it's absolutely been extraordinary for these patients. Interestingly, back in the late 60s, a famous neurosurgeon named Irving Cooper did a procedure where he burned an area of the brain in a patient with epilepsy, and it slowed down the epileptic focus, and it slowed down the epileptic seizures. And that area was the anterior nucleus of the thalamus. And that means nothing to you guys, but it is a very centrally located nucleus, and it is, so this is your brain, okay? Here are your eyes. The anterior nucleus is right in the middle, and it actually has connections with the tracts that go from the hippocampus and then the mammillary bodies, which are down here, which are very important for memory. But this circuit right here, and then it goes to the frontal lobes, this circuit possibly can be thwarted from its epileptic discharges by stopping the function here at the anterior nucleus. And so what Dr. Cooper did was he put an electrode in here and burned that area. When you burn it, it sometimes heals, and it also you may miss the right spot. And when you burn an area that you don't want to burn, that's pretty bad. And that's why those days are over. So now we can actually put a stimulator in there, hook it up to a pacemaker here that's in the chest, and we can stimulate it in certain ways, right? We can change the pulse with the rate, the frequency of the stimulation, and the voltage. And that's what this battery does. And believe it or not, Medtronic got the FDA approval to do this within the last year. So we at HOAG are one of the first hospitals in the country to be able that are qualified, that have received the credentials to put this in. And why do we have a step up about it than everybody else is because we've been doing it for 22 years for Parkinson's disease. So for us to put in an electrode in the brain and target a certain area, it's the same as targeting for Parkinson's, which is a different nucleus, different area. When I do Parkinson's surgery, there are 3 targets that I use in the brain, depending on what they've got. If they've got stiffness and rigidity, I target one area. If they've got a tremor, I target the other area. If they don't have Parkinson's and they have a tremor, I target a 3rd area. This is a 4th area now called the ANT, the anterior nucleus. And that is the latest and hottest little thing for epilepsy. Now we leave it to people like Dr. Mehta and Dr. Millett, you may have met, but Dr. Millett is the director of our epilepsy program from the neurology side. Vic and I are both neurosurgeons. But you get a guy like Dr. Millett to do the workup on these patients, and he says, aha, this patient will do great with anterior stimulation. So it's a whole process to figure out who's going to be responsive to this. Right? So it's fairly new, let's admit that, but the target is as old as 1967. And they started doing stimulation on this in the 1987 era. And Medtronic just picked it up and went with it. So it's an interesting concept, and it's all about, choosing the right patient, once again, and we leave that to the epileptologists to make that decision. Where we're going here, the whole picture, when I started neurosurgery, which was in the 80s, 1986, the only thing we had for epilepsy was whacking out the temporal lobe. I mean, that thing is the size of a small banana, right? Like a plantain. And, you know, just removing that whole area of the brain is very destructive, very, very aggressive. So where we're going now is much more refined, it's much more targeted, and it's far less invasive, right? So all of us who are in the non-invasive world of neurosurgery, this is where things are going, right? So, I mean, you're looking at this model here, it's got a hole the size of, that's like a 1/16 of an inch drill hole that this is going through into the brain. And it is, you know, that's all we need to do this procedure, which Vic will talk about it. But the concept is when in the old days, oh, this thing's heavy. In the old days, you see that big sausage there? That whole sausage would be cut out. Now, we stick an electrode in there, and we burn that area. And we've done the same thing that we've done without doing major brain surgery. Okay? These patients go home the same day.
Yep. Yep.
They come in the same day. So we have refined the techniques for neurosurgery on epileptic foci in a very beautiful way. It's very minimally invasive. So he's already described two techniques, the VNS and the RNS. I just described the DBS. It's all these initials you got to remember. And that is very exciting. We're just ready to do those here at HOAG. And finally, we'll talk about laser ablation, which is yet another way to manage these types of seizure foci. Okay? So I'll go back to you.
Thanks, Chris.
Yeah.
You know, DBS for epilepsy has been approved in Europe for several years. So there was a lot of data in Europe, and patients were getting it. And you know, our approval process takes longer, but this is something that's been around, and the data is very promising, especially for those patients who are not candidates for any type of resective surgery, or the seizures are coming from so many different places. It's just impossible to target one area. Similar to vagal nerve stimulation, which targets the whole brain, DBS targets the whole circuit where the seizures are coming from. Any questions about DBS for Dr. Duma? Probably.
It's just a constant.
Yeah, it's on all the time. Yeah, you just set it and forget it.
Yes.
So what if that part of the brain is already damaged?
So the idea is that there's some scar or there's some abnormal circuitry that's developed, either you were born with or developed over time, and it's sending electrical activity in an abnormal way. By delivering a stimulation, we're hopefully resetting that electrical activity. We're asking the brain to fire in a more normal way.
A little more resynchronization.
Yeah, that's a good way to put it.
Resynchronizing the brain.
So this is one of the coolest things, and Dr. Duma and I do this together. This is laser ablation. And what laser ablation is replacing is doing an open brain surgery where we cut out a piece of tissue. There is a structure in the brain called the hippocampus, and next to it is the amygdala. These are structures in the brain that when they have abnormal development or scar or injury, cause something called mesial temporal lobe epilepsy. It's just a fancy kind of way of saying the inside part of your temporal lobe, okay, the part of the brain here on the side, is scarred. And that area of the brain in patients who are right-handed, if it's on the left side, also happens to control a lot of memory. And oftentimes it's also involved with recognition. And that's deep inside. Further out on the surface of the brain, on the left side, it's also involved with speech. So what Dr. Duma was mentioning when we were cutting out that piece of the brain, and we were still doing a lot of that, I mean, it's still a lot of that is being done. We were putting a lot of patients at risk of speech and memory issues. But if your seizures are so disabling, you're having 5-6 seizures a day, you can't drive, you can't work, you can't go to school, you take medications, and you're just laying in bed, well, we have to do something and get those seizures under control. So we would justify doing an open craniotomy to cut that area out and say, well, something is better than nothing. Well, what we realized is there's better ways to take out that tissue. And what they developed was this concept of laser ablation. And what we do with this laser fiber is, just like Dr. Duma mentioned, we make a hole about the tip of a ballpoint pen. And we do that by placing your head in a frame, drilling a very small hole, and under very sort of precise guidance, placing this laser fiber right into the area, if you can see that sausage-shaped structure, right into that structure. We then put you into the MRI machine, and under MRI guidance, we apply heat through the laser fiber. And we can shape and mold and contour that heat to only destroy the areas of the brain that the seizures are coming from. And that's usually the head of the hippocampus, the body, the amygdala, the parahippocampal gyrus. These are all structures of the brain that very classically cause this particular type of seizure disorder that's very, very responsive to surgery. So if you've heard of things like temporal lobe epilepsy or mesial temporal sclerosis, things like that, those patients do very, very well with surgery. The cure rates, we're not talking about control rates, the cure rates for those patients with epilepsy is really what we're aiming for. The gold standard for this type of epilepsy is the removal of the brain. That cures seizures in about 60, 70, maybe 80% of patients, but there's also a lot of side effects of that surgery. Difficulty with speech, memory, sometimes headaches, infections, other complex things associated with having large sort of brain surgery. It's a 4 to 6 hour surgery. You're usually in the hospital for several days after that surgery. With laser ablation, we can do the same thing. The laser on time, the time we're actually destroying the tissue, takes about 25 to 30 minutes. Now there are several other steps. We've got to put you to sleep, put the frame on, put you in the MRI, bring you to the OR. All those steps probably take about 4 hours, but the actual time of surgery is only about 25 or 30 minutes. We then take the fiber out, put a little stitch there, and you go home. This has been around for about 4 or 5 years. The data every year gets better and better for laser ablation. When it first came out, maybe it was in the 40 to 50% range for cure, no seizures or very, very few seizures at 1 year. The more data we get, the better it looks. We know the side effect profile is much, much better. Memory and speech issues, much less issues with that. Infections are virtually non-existent. Hemorrhage in the brain is very, very small. Maybe a 1% chance of a small hemorrhage that you may not even know. We just see on the picture. The great thing about laser ablation is it's targeted, it's focused. It doesn't touch any of the brain that isn't involved in the seizures. And for example, if you have an area that's ablated and you do really well, but you continue to have a few seizures and we see there's a little rim of tissue still involved, we can go back and retreat that area either through the same incision or one nearby. So this has been really powerful. We've done our first sort of series at HOAG and we're seeing good responses. You've got to have the right type of epilepsy to be a good candidate for this procedure. Any questions about laser ablation?
Is it only being used for medial temporal lobe epilepsy or are there other focal epilepsies that you're looking into?
Yeah, they're using it for things not only epilepsy related, like cavernous malformations of the brain or even some types of tumors or responses to tumors. If there's a seizure focus that's deep in the brain that's not temporal lobe epilepsy, we can also treat it with that. For example, we're about to treat someone with a low-grade brain tumor. It's not in the hippocampus, it's in the amygdala. But instead of going there, opening the skull, taking that out, we can just laser it, just heat it up and destroy that little small area of low-grade brain tumor. And our goal is not only to cure the seizures, but cure the patient of the brain tumor as well. Yes?
Are those, is it possible if there are things that are missed in a temporal lobectomy 20 years ago to do this now to finish the process?
Yeah. For example, if you had a standard temporal lobectomy and they didn't go far enough and there's maybe still some tail of hippocampus, or up front there's some piece of the amygdala or parahippocampal gyrus or other areas that the neurologists say, we think the seizures are coming from there, you're definitely a candidate.
That's almost an ideal situation, you know. Little piece left, this is perfect for it.
From a recovery standpoint, it's remarkable. I mean, people are back to work, back to their normal lives in the next day.
We just got the 5 minute.
Oh, 5, okay.
Right, so we have 5 minutes left. We have any more presentations to give? Or?
No, this is it.
Yeah, let's open it up to more questions then. Anything else?
Yes, we can talk to Dr. Millett and see if he wants to recommend that. Yeah. Yeah. The big idea is that 5 years ago, we didn't have 3 out of these 4 things. So in the last 5 years, our options to treat have expanded so much. For patients who are being told, well, you've got seizures, there's nothing to do, take these medications and see you next year. Now there's so many more options. And hopefully by talking to surgeons and the vendors and the companies that are out there, you guys get a sense that there's something for each patient with epilepsy. There's some type of advanced device that we can employ to help get you off of the medications, to reduce the side effect profile, and to give you some quality of life back. So, you know, do your research, ask a lot of questions. You're at the exact right place you need to be to get this information. So, yes.
So the DBS is like the DNS, that it's more generalized.
Mm-hmm. Yeah, it works on the whole circuitry of the brain that's involved.
Just because you're targeting an area that's like a hub for the network.
Yes.
Are most of these covered by insurance?
Yeah, these are all FDA approved. They're all covered by Medicare, which means they're all covered by the other payers. So you work with your epileptologist who submits an authorization. But I don't know, you may have read the story about the young girl who, I think it was Aetna or Cigna, denied her laser ablation, and it became a big story. They said, well, no, you need to have an open craniotomy, temporal lobectomy. And she fought it, and she won, because she wanted this. She wanted a little pinpoint incision. She didn't want the big surgery. So we, as the doctors, we do our part. We really go to battle for you guys to make sure the insurance companies are paying for these therapies that are FDA approved. Other questions? Yes.
Is there any artifact on the EEG from the DBS?
You'd have to turn off the DBS to do the EEG. But you can do that with a little device that you can, that you have.
Yes.
Is that also possible to do that surgery if you've had a temporal lobectomy and have an RNS?
Can you do a DBS?
Yes.
DBS, if you've had a temporal lobectomy and you have an RNS, we will find out. DBS plus RNS. Do we have?
I'll tell you, there's a couple of things that we have to look out for. One is that the 2 devices, let's say you've got the RNS here, we would have to be at least 10 or 12 centimeters away with the other generator. That's number 1. But you'd have to talk to the actual the companies to see whether they're compatible. And that's where we would go with that. We'd have to talk to the actual, we talk to Medtronic or NuPace.
Yeah, so I'll give you a card, and then if you email me, I'll find out for you. Yes.
So in addition to epileptic seizures, I have hypotonia, non-epileptic seizures. With surgery, what's the book?
So it's a good question to ask your epileptologist. Generally, the non-epileptiform pattern does not respond to these stimulation, to these resynchronization strategies and the stimulation. But there might be a component, for example, vagal nerve stimulation or other treatments may be possible. But do you have an epileptologist who is familiar with all these different types of surgical strategies for seizures?
I go to neurologist.
Okay. Okay. Yeah, if you grab one of our cards, we can connect you with people who can address that question. It's a better question for the epileptologist, but we can help you get connected. Other questions? How do you guys like the expo? How many is this first time?
I love the dogs.
Yeah,
I mean,
it's great.
You know,
Who's been here before? Okay. Whose first time is it? Okay, so that's great. Yeah. No, it's amazing. I mean, really one-stop place to learn about the whole spectrum from dogs to surgery. It's they say from dogs to dogs, but I didn't want to say. But
old dogs.
Yeah.
Great.
Well, thank you guys for coming.
Yeah, good
Feel
question.
free. Yeah.